welcome everybody. This is kind of a lecture that I actually gave this 3 years ago, but I think it's good, quick information to remind people who are, taking care of pregnant women, especially labor and delivery is probably where I see some of the biggest confusion about exactly how to manage patients. Um, and I think there are a couple of things to think of. Uh, what are the physiologic considerations with substance use and pain management? Um, Briefly, what are the options for labor and delivery? What are the options for management postpartum? And then even some breastfeeding considerations for patients. So, as I probably don't have to remind everybody, is these tend to be very complex patients, no matter chronic opioid use, whether it's substance use disorders or medical management therapy, et cetera. They can be pretty complex. I don't have a slide on this, but I do want to remind people that when patients come to you and maybe they're in pregnancy, and I find that it's very unfair to some of our pain specialists that are maintaining patients on opioids and things like that will all of a sudden do a peek and shriek and, oh my God, you're pregnant. When in reality, what needs to happen is we need to work together and come up with a good plan for the patient. And I think the dictums that I use are, first and foremost, are opioids the best method of treatment? And I'm sure anyone who manages pain, if that's what they're utilizing, it's probably hard to convince them that there are maybe other options sometimes. And so I think and what we'd like to do is, at least decrease the amount of opioids, if at all possible. And many patients who might be opioid dependent also have significant mental health issues many times, and they might be on other medications, not to mention stressors of life and polysubstance abuse, et cetera, that might be complicating their care. So opioids, just simply, modified approach is required, but let's remember, everyone deserves adequate pain relief, okay? There's no reason for inappropriate selection. You never should be withholding pain medication. And patients should be receiving an adequate dose if you're going to use the medication. Well, what are the major, physiologic considerations? Well, I think in people who have utilized opioids for a significant period of time, no matter how, hyperalgesia is very, very common. And hyperalgesia, as I'm sure many of you in the substance use realm know, is not uncommon with other substance uses like methamphetamine and things like that. Second, there's tolerance, which is basically that state of adaptation where it takes more and more of a medication to receive the same effects. And then there's physical dependency, which is, manifested with withdrawal, especially with abrupt cessation. And then the opioid debt, which I guess in my mind is kind of similar to tolerance in the fact that, you basically are going to require more medication to overcome that debt before any analgesic effect is really, really appreciated for the patient. All right. First and foremost, patient comes to the hospital, labor, surgeries, anything like that, and they're receiving methadone or buprenorphine. Do not reduce or change their dose in any way. I think sometimes our anesthesiologists and many of my, obstetric colleagues, think that, oh my God, this is all going to interact and going to be a problem. When in reality, it is not. Um, I mean, I think if someone's in labor, nitrous oxide is one option. Um, People have various feelings about the effectiveness about nitrous oxide, but that can often help get women through at least the first stage of labor. Um, IV narcotics, fentanyl, hydromorphone, or similar short-acting agents are very appropriate. Um, but the biggest thing to remember is because of those physiologic changes, they probably will require higher doses. Um, and then last but not least, epidurals, neuraxial analgesia, spinal, those are very effective. Um, but for an ongoing like epidural, they might require more boluses because their mu receptors are probably fairly um, saturated. But we do find that, especially with the other medications, the lidocaine or a type of canes that are in it, that probably most everyone gets good relief. So there is one big definite no-no when you're utilizing agonist antagonists, okay? With, any sort of opioids that someone has been using on a chronic basis or they are dependent on, that the antagonist aspect of that, it's very similar to, say, buprenorphine in the fact that the antagonist aspect can and often will induce acute withdrawal. So I think, sometimes the use of or at least historically, the use of the agonist antagonist was thought to, really, help us, prevent, any sort of opioid, exposure, et cetera, or maybe less, I don't know, addictive. I don't know exactly what the thought was, but the point being is it's not to be used at all in these patients. All right. So that's basically labor and delivery in a nutshell. Um, from a postpartum vaginal delivery standpoint, basically when someone's in the hospital, if they are on a maintenance dose of buprenorphine or methadone or pain medication, that should be continued just without any changes. The only suggestion is maybe splitting the dosing up a little bit over 24 hours, as it says there. Break it up every 6 hours for buprenorphine, 12 hours for methadone. And then, liberal use of nonsteroidals and acetaminophen is recommended. When it comes to pain relief, especially post C-section, which we'll talk about in a little bit, I think it's extremely important that you probably schedule the nonsteroidals and the acetaminophen. And then if they do need some short-acting opioids in the first 24 hours or so, then I think it's reasonable to utilize some of those on top of that. Vaginal delivery, I think especially the more babies you've had, we find that that first 24 hours, especially while breastfeeding, that crampy uterus can actually be a lot of pain. But again, dose requirements might be higher. And when I say dose requirements, I'm talking about the nonsteroidals as well as the acetaminophen because of the hyperanalgesia. So, and then of course, breastfeeding is encouraged for all women who are on, medical management treatment. So, all right. Same thing here. Don't change the methadone or buprenorphine. Spinal is very appropriate for scheduled cesarean delivery. And like I said, an ERAS or I forgot what ERAS stands for, but it's the a proactive way of managing pain, which is utilizing sometimes some protocols use gabapentin, maybe even before the procedure, and then scheduled Tylenol and scheduled nonsteroidals are utilized, then utilizing the opioids for breakthrough. So, all right. That's what I just got myself going on that, didn't I? The postoperative cesarean, uh, again, don't forget daily maintenance dose. Certainly, that first 24 hours is going to require the most support. Some people utilize a PCA with short acting, high potency things such as hydromorphone, fentanyl, morphine. The other thing that's also available are the transabdominal plane blocks, which is basically a way of injecting, lidocaine or in around the innervation of the abdominis to help improve that abdominal pain. Um, Usually it's an anesthesiologist. Some surgeons actually do it themselves, but anesthesia is usually our go-to for that type of procedure. And then, of course, after 24 hours, the nonsteroidals, acetaminophen, and then I think people estimate somewhere that a patient's going to need anywhere from 50 to 70% higher dose of opioids if you're going to augment them on top of that. All right. 5 to 7 days of opioid prescriptions should certainly be sufficient after C-section, or, if someone has a very extreme perineal trauma from their delivery, from a vaginal delivery. And again, treatment of pain should be similar to other patients. Really emphasize the non-opioid pain medications. Guess what? Acetaminophen and nonsteroidals is best practice. We definitely believe in our practice that if patients call back for a refill of any opioids, they should be evaluated in person. I think it is important to make sure that we aren't missing a complication. It also sends a message of, we're being very thoughtful about the use of the opioids, which I think is important for us to convey to all of our patients. And then if there are pain issues, sometimes people will be utilizing opioids to help, deal with their anxieties or what might be brewing postpartum depression. And then of course, you want to be careful about diversion, etc. Breastfeeding's easy. It's encouraged in all women who are receiving buprenorphine or methadone. And minimal amounts of the medications might be in the breast milk enough to make a baby drowsy. At the same time, a little bit may be helpful to prevent withdrawal in the neonate. So just so you know, codeine and tramadol are contraindicated in patients who are breastfed. Basically, and it has to do with, there is an occasional baby who will actually have a liver metabolism issue that changes how they break down codeine in particular. We don't use it at all anymore in the postpartum, especially with breastfeeding, because it can actually be toxic for babies. But it's only kind of with the codeine and the tramadol that we see that. And again, anytime mom's taking medications, the baby should be monitored for any sort of drowsiness or, untoward side effects, failure to thrive, etc. So just to kind of key points, continue those daily maintenance doses. Uh, Chronic opioid exposure may require higher doses of medications. Avoid agonist antagonists. Um, Duration of pain treatment should be similar, but may require higher amounts of medication. And then, of course, breastfeeding is encouraged. And any questions?
So I appreciate the presentation. Meds are like totally out of my scope. But I think the part that I learned the most about was the breastfeeding piece, just because we do end up having a lot of pregnant women come through that are opiates are their drug of choice. So it's good to know that they're going to be okay on MOUDs and still breastfeeding.
Absolutely. Yeah, and in fact, we highly encourage it, and some people utilize that as a way to prevent, withdrawal in the babies a little bit.
One thing that I run into a fair amount, I don't do OB any longer, but I do take care of a number of patients who are pregnant, is women who have had really bad experiences on L&D previously and are anticipating horrible experiences again. And I spend a lot of time trying to talk them away from the ledge on that, including even uh, trying to connect them with people on labor and delivery so they can go up for a tour and that kind of stuff. But I'm wondering how other people deal with that. The anticipatory disaster, I guess, is what I would call it.
I think that's an excellent point. I mean, yeah, there are situations that are absolutely horrible, and I think I like your approach. Other than just trying to be as reassuring as possible, making sure that the hospital care team is aware of maybe what someone experienced before. I think that's another big thing to make sure is clear. I would say the other thing is if another thing is if you do have a case where a patient has a bad experience, I think it's really important to address that in the postpartum period to give them a chance to heal around it so that when they come back to you for the next pregnancy, um, you're not kind of starting from a place behind the eight ball, so to speak.
I encourage patients to make sure they have a good, like start talking about their birthing plan with their doctor at least a month ahead of time so that they're both on the same page and that information can be shared with the staff at L&D. So just having them start thinking about those things, the sooner the better, and then working those things out with their doctor. I feel like that's been actually really successful for patients.
It seems to me, my perspective is that there's not as much penetration in the surgery and anesthesia literature about management of these patients as there needs to be. I still, I mean, even the other day I had a patient whose oral surgeon had told them to stop their Suboxone at least 48 hours prior to their anticipated extensive dental surgery. And I spent a lot of time trying to pick up pieces, calling people's offices and talking to people, but I have trouble sometimes making headway on that. And I wonder why it's not better known in those surgical and even anesthesia communities about how to better manage these patients.
I think that's a great point, and I guess that's why I come to these things and try to help spread the word. I don't know if it's kind of like singing to the choir here on Echo, but I figure the more we can do that, the better. And I would extend that to any psychotropic medication for moderate to severe mental health disease as well too, you know, is how do we get people to, not change around pregnancy or when there's a procedure, you know, change those medications.
It was one of the things I guess is looking for opportunities of education with staff, because I've seen nurses. I mean, I've overheard nurses deem somebody not worthy of being a mother, and then non-verbally conveying that to the patient. That when we have opportunities to share that with other staff, helps immensely with the whole holistic care of that individual. So
I totally agree. You know, we do a clinic with pregnant women, and I think we get a lot of feedback about how they were treated when they got to labor and delivery, and I think we're doing a much better job within our institution now, but it's taken it takes a lot of work. It's a culture change for sure.
Jake and Kathy, I want to give you guys a chance to add any thoughts or ask any questions if you'd like.
I have a lot of questions. I really appreciate you being here, and I loved your presentation. I think one of the things that I try to reiterate with patients is I've had people say like, oh, pregnancy changes everything, and then I'm going to stop these meds, and they don't want to listen to the risks of relapse and things like that. I've seen that very infrequently because I work at the VA, so I don't see a lot of pregnant women, but I have seen it, and I think it's just very powerful to hear from somebody who is trained as an OBGYN, who deals with pregnant patients for your entire career, to be able to also say, no, these medications are indicated and you should stay on them. So I just am glad to hear that. That would be my only comment. Thank you for the presentation.
Thank you.
Thank you. I thought it was a great presentation too. I liked how you pointed out with the codeine and tramadol, right, not being used for, breastfeeding moms due to the, potential of the mom being the ultra rapid metabolizer, right, and having higher levels of that active drug crossing through the breast milk and causing pretty significant issues, right, in the baby. And I don't deal much with pregnancy either in my practice, but kind of going back to the comment about, I think Dr. Reagan brought it up, that why is it that surgeons or, anybody in the surgical world sort of doesn't know what to do with patients on either SUD or something like that. I think it's key that all of our patients know that if they are going for a planned procedure, right, there's a pre-op usually visit and such to be sure that they're addressing it at that point, because I think if it can be, worked around there and then it just moved forward, right, instead of at the time of the surgery or post-op and nobody knows what to do or they're told to stop their meds. I do think it's really important that the patient be educated that they need to somehow initiate that conversation, right, when they go in for those planned pre-surgical consults. So just kind of, because my husband works at a surgical hospital and I know that happens, that nobody even knew about it. And then it's like, so I do think that proactive is the best way and promotes patient safety and comfort. So
I have a question, and this might not be the group, or it might be the group. I was just wondering what different institutions, policies and such, just get a feel on reporting of patients who have opioid use disorder, who show up pregnant, what that, I mean, I know seeking treatment, like that's one of the biggest barriers, right? This fear of being reported. So I was wondering what the current situation is in Idaho and what you guys are seeing.
Not a hospital, but an agency. And what I have been told by CPS is that fetuses don't count for mandatory reporting with use. That's what they told us. Whether or not that's changing with some of the rules that are coming with like treatment of minors, but I thought it was kind of interesting with politics and legislation in Idaho. If it's a pregnant person, it's not reportable.
No, I'm pretty clear there are no penalties, and that's one of the things we really try to do is make sure that it's welcoming. Certainly if people have relapses during pregnancy, we encourage them to continue to come, and we understand that's part of the process, and we're never going to kick them out or refuse them care. And yes, I think it is required at birth that substance use is reported to CPS. CPS then will do a very quick investigation, and truthfully, there are so many more things that go into CPS's involvement, the social situation, and, is the baby in danger, I think is probably the bigger issue when it really comes to, them getting involved or, considering foster care or something like that for the baby.
And then thank you both. Any follow-ups? Has anybody experienced or like heard of strategies to help moms keep their babies during that reporting period?
If they express that they're nervous about it, I certainly just encourage them to do the best job they can. And, we try to document as many, urine drug screens through the pregnancy, whether they're on medical management or not, and can offer that up for evidence if at all possible. But yeah, and I think, just trying to help them, and this is another big thing when it comes to pregnancy that I'm a big believer is that, as someone said earlier, everybody's going to get off, I'm gonna stop using or et cetera, or get off my medical management. But I think the point is that it's a time when women are motivated, and if you can get them to a place where they have adequate counseling and support, that then they can be handed off to for long-term treatment is my goal as an obstetrician. I would say, other than that, I can't think of anything that would be that you can really do proactively if you've got a lot of other risk factors, like homelessness or, violence, et cetera. I don't know. Are there any social workers on that could address that?
I work at the Department of Health and Welfare Child Protection in the Boise office, and we do get calls after delivery if a baby tests positive, even for THC. And you're exactly right. We start an investigation right off the bat, and it triggers a lot of support, a lot of suggestions, but it may also trigger opening a child protection case. So it is scary when we do have a lot of empathy for new moms and new dads, because it's overwhelming.
Thank you.
Yeah, thank you, Katie. Do you see, is there something that moms can do that you've seen that like kind of helps them establish their, like, makes them look better in your eyes, or I mean, I guess the one thing that I heard is like a plan of safe care is something that I've heard that social work can put together. Have you heard that term before?
Plan of safe care for the baby.
For the mom, and like it's basically like a binder they put together, and it's like all their UAs and like any counseling they've done and like all the steps that they've basically like, you know, if you go into like, I know, court or something, you're putting together your case, like, look how great of a mom I'm going to be. Or, you know, look at all the steps that I've done to show that I'm, you know, on the right path.
I'd ask Ms. Blake what her thoughts are on that.
Yeah, that's kind of where it's going with that.
If we do open up a case and we do go to court and it is a child that's coming into foster care, the department works with the birth parents to create their plan. The parents are very proactive and engaged in that process, and so is the court. So if treatment is needed, that's part of their case plan. Utilizing other supports can be part of their case plan. It's that kind of window of showing that the birth parents have addressed the conditions that brought the child into care that allows for a child to be reunited. Sometimes in that process, the child is not removed if the circumstances can allow that, but typically it does trigger our process in that way.